node, which is a little bit enlarged. Sebaceous epithelioma is a benign tumor, but because the lymph node is so big, I'm going to go ahead and take that out as well. Can I get some sponges, please? If you haven't already subscribed to our channel, please do so. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I've got the popliteal lymph node pinched here between my index finger and thumb. I'm just going to make an incision on the back of the leg like this, and this is essentially like a castration. We're popliteal lymph node, we're squeezing out like you would a testicle. And there it comes there. And I'll just grab that. So that's the lymph node sticking out here. And I'm doing the lymph node first because in case this was a malignancy, we would want the lymph node out first because we wouldn't be concerned about margins. Whereas if I did the tumor first and I got a dirty margin on it, I would be contaminating my lymph node site. So very straightforward, getting that out. Cautery certainly helps. So that's the lymph node out there. Can I get some 3O PDS, please? Sure. I'll hand that off as well. All right, so I'll just get some PDS and just do a little intradermal suture pattern. Our special guest surgeon, Rachel, arriving. So can you just turn that up like that? Do some deep sub-Q. It's kind of between the semitendinosus and biceps femoris. Might be semi-mem, semi-ten at that point. Morning, Thailand. If you guys want to let me know where you're watching from, that would be great. I've got a little sebaceous adenoma up at the top here that I'll remove at the end of the surgery as well. San Francisco, South Korea, Ontario, Los Angeles. And so now I'm just doing a little intradermal suture pattern. So we're going to create a big open wound on the plantar surface, the metatarsal region, to remove this epithelioma. It's about 4 centimeters in diameter in this pretty small dog. So what are our options for managing that open wound as far as reconstruction or closure or whatever? What would our options be for managing the open wound created by removing a large tumor from the plantar surface of the metatarsal bones? That's a quiz question for everyone. Now there's something else that people often ask me about is, could I do lymph node mapping for this? And you definitely could. I haven't done a lot of lymph node mapping. I've probably done a dozen cases, something like that. A friend of mine, Julius Liptak, is a surgeon in Canada that does a lot of it. Basically what you do is you either inject methylene blue into the tumor and then trace the ink as it goes into the lymph nodes to identify which lymph nodes are affected. The other thing that you can do is inject contrast material and then do a contrast enhanced CT scan. Do a CT scan with just the contrast in the lymphatic chain to see which lymph nodes are affected. And you have to remember that when we do lymph node mapping and we remove the affected lymph node, it's not going to be therapeutic, so we're not trying to cure the patient. We're just trying to use it prognostically to identify if there are metastatic cells in that lymph node. And I certainly wouldn't do it in this case because this is not a tumor that metastasizes. So let's have a look here. So that's the tumor sitting there. I might try to reposition my camera a little bit. Got a little plastic bag here. So somebody has said second intention healing, which is exactly what I will use in this situation. All right, so I'm going to hold that up like that for me. Now, we are going to have some bleeding from this, and so there's one other thing that we could do, which is to use a vet wrap and do what's called an Esmark tourniquet. So we'll go ahead and do that. The problem with the tourniquet is that it won't bleed during the procedure, but then as soon as I take the tourniquet off, it's going to start bleeding all over the place. So then I have to identify all those bleeding vessels, but at least it makes it a little bit easier to see as I'm doing the procedure. So what we do with an Esmark tourniquet is I've got my vet wrap here. I'm going to go up over the tarsal joint. I'm going to pull this as tight as I can, and then you actually put a little twist in it, like this, which is going to really constrict the arterial supply, and that can be on for about 20 minutes. Another little twist. So we'll set a timer for 20 minutes, although I'll be well and truly finished with the surgery by then. All right, so now we've got that tourniquet on. We'll flip this up like this. I'll start my incision. And sebaceous epitheliomas do not metastasize, but if you don't get the whole thing out, they certainly can recur. So I'm just going around the whole thing. And the question is going to come up is, do I need to sacrifice the flexor tendons? And you can definitely, if you feel like you need to, you can definitely sacrifice those flexor tendons without any effect on mobility. They will be kind of flat-footed. Again, because this is a benign tumor, I'm going to try not to. But if I get in there and I feel like that's what I need in order to be confident with my margin, I won't hesitate. I'm just seeing how adhered this is to the underlying tissue. And we are getting venous bleeding here. I don't think we're getting arterial bleeding because of that tourniquet. I am cutting my superficial flexor tendons. So you can see the deep flexors are still intact. Alright. So what we're going to do is we're going to get a hemostat on here, and I'm going to get Rachel to retract on that. I'm trying to ligate my vessels as I go. So that's what we've got there. You can see that that's so Ryan, the reason why we removed that lymph node was because it is the draining lymph node for this area, and it was quite enlarged on palpation. So even though it's quite distant, since it is the draining lymph node for the area, that is the next thing that would be affected if you did have metastasis along the lymphatic chain. So that's why we removed it. All right, so we can see here that that's nice and dry. I can't see any big vessels here. So I'm going to go ahead and remove the tourniquet now. And you will see that it is going to start bleeding. So I'm just going to have to address the, thank you. I'll just have to address the bleeding as I see it. Hopefully I'm not going to create another big incision with my scalpel blade. Have seen it done before. May have done it myself. Can't remember. Wouldn't admit it if I had. Okay, so now we'll just give it a few minutes. So there's interestingly, the arterial bleeding is coming from distal. We'd expect it to be coming from proximal. And these incisions, tumor removals, are really annoying because these are the ones that you're going to get re-bleeding, or I get a call in the middle of the night that the bandage is soaked through. So it's not bleeding too much, just a few little bleeding vessels, but nothing too bad. Give that a little squeeze. Yeah, that's all good. All right, so now what we're going to do is we're going to put a non-adherent bandage on. Can I get some melalin, please? So there's a question, can I remove the tumor first and then the lymph node? You could do that. I removed the lymph node first during the surgery because the lymph node, if I get a dirty margin on my primary tumor, then I'm going to contaminate my lymph node site. Whereas the opposite is not true. If I get a dirty margin, you can't get a dirty margin on the lymph node, so I don't need to worry about contaminating my primary tumor. So some tape, please, for a, like brown tape or white tape. I'm going to put a little stirrup. Yeah, heaps. I'm going to put stirrup on the front of the leg here. Thank you. When you put bandages on, particularly ones that cross the tarsus, there is a chance that you're going to get create a tourniquet effect and get necrosis. So I'm really careful with putting bandages on that are going to cross the tarsus, and so my preference would be not to cross the tarsus with this, and that's why I put the stirrups on. Just drop that down a little bit. I'll zoom out a bit so you can see the bandage. So that's the stirrup right there. The key to a good bandage is putting on lots of cast padding. Okay, and then this is cling. By not going over the calcaneus, I'm less likely to create a tourniquet at this level right here. Okay, so now I'll separate my... Now when I do stirrups, I want to make sure that my toes are exposed so I can tell if we're having swelling. And we warn the clients that if you get any swelling of the toes and the two toenails can't touch each other, then immediately take that bandage off. Even if you can't get back to the vet practice, I'd rather have it as an open wound and have the owner put a sock or a Band-Aid on it than to have that tourniquet on for an extended period of time. For any period of time, actually. I won't use elastoplast. I'll just use brown tape, please. So you can see here that the toenails are nice and together. And if they were to come out like this, that would tell us that we've got a tourniquet effect from the bandage, and that would have to be removed straight away. Okay, so that's pretty much it. Now the bandage will have to be changed in about 3 or 4 days. And we'll do that for a couple of weeks until we've got good granulation tissue. And then we can go every 5 to 6 days. So, and this should take about 6 to 8 weeks to heal. So, and granulation tissue and reepithelialization is basically the same bandage technique. So, well, that's pretty much it. And so we'll go ahead and end the live stream. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications